the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, pain psychiatrist, Dr. David Marks. Dr. Marks, welcome back to the podcast.
I'm very happy to be with you again, Sam.
You had talked about aberrancies in pain management, and you said we could do an entire podcast on that. And so here we are. I wanted to talk some more about that. I did some research and I realized there are many different types of aberrant behaviors. And my goal is to try to help all of us who prescribe opiates to be aware of some of these. How would you define aberrant behavior in general? And are there specifics to pain management?
Well, aberrant drug-taking behavior is essentially taking the medication outside the way it's prescribed or the way it's been instructed to be taken by the prescriber. I think largely the term refers to when patients are prescribed controlled medications and there's a concern that they're taking them in a way that is dangerous to themselves or to the community, or in a way that is just really medically unsanctioned. So probably our population of clinicians does have a lot of experience with dealing with aberrant behaviors. In the chronic pain population, we are a lot more vigilant about aberrant behaviors, just in the sense that when we're balancing the risks and benefits of chronic opioid management program, it's oftentimes different than managing the risks and benefits of acute pain management, something like after a surgery or after an injury, where I think in general, there's a little bit of a higher tolerance for aberrancy. And, when you do a risk stratification, so to speak, patients that need opioids for an acute pain syndrome, unless there's really extreme risks, it's still advisable to prescribe opioids for a post-op patient, for example, or a patient with a serious trauma or something of that nature. What we do in the chronic pain world does translate to the acute pain world. And, by way of example, I've seen some patients that have been referred to me from the orthopedists in my practice, where they were just a little uncomfortable about prescribing acute opioids for a post-op patient. And they had me involved in the strategies of trying to reduce the risks of aberrancy in patients that are going to take opioids post-op.
In researching this, I read a publication on aberrant behavior, and it was specific to patients in pain management. And I know you'd mentioned that you'd seen this before, but just for our listeners, they broke it down into two categories: behaviors that are worrisome for addiction and medication abuse, and behaviors that may seem aberrant, but are really the patient trying to manage their pain symptoms better and probably will not lead to abuse. What are your thoughts on that?
I mean, I think what you're saying is that not all aberrant behaviors are created equal. And I completely would sanction that concept. I think the paper you're talking about is from Steve Posseck's group, Posseck and Weinraub, in 2000. And he talked about how aberrant drug behaviors, there are some that are more predictive of abuse and some that are less predictive of abuse. Not that those that are less predictive of abuse should be ignored, but some of the examples he used was something like forging prescriptions or stealing somebody else's medications, or taking the medication in a way by a route that it wasn't intended, like injecting or snorting an oral medication. I mean, those are all obviously very predictive of abuse. Some things that would be less predictive of abuse might be, requesting specific drugs, like, well, I know Dilaudid works really well for me, or, kind of hoarding drugs during periods where your symptoms are not as bad so that you have enough at times when your symptoms are worse. Those types of things are less severe in terms of the abuse potential. Almost all of us that study this and talk about this refer to that paper quite a bit. It's become something of a landmark paper. The premise is that when you're intervening with aberrant behaviors, you really want to have a plan that is commensurate with the level of the aberrant behavior, and that specifically addresses the behavior that you're seeing. And this is the level of sophistication that we're advocating that chronic pain clinicians and to some extent people treating acute pain, such as yourself, are operating in. Because so many times what I see in my practice are patients who had an aberrant behavior and then they're booted from the clinician's practice. I've seen more lenient clinicians that we'll basically say, well, three strikes and you're out, and three aberrant behaviors and you're out. And, to me, that lacks a certain amount of sophistication. I mean, we're not playing baseball and counting strikes. We're trying to come up with an opioid treatment plan that we adapt when new information comes in about the risk benefit profile. And that's what intervening with aberrant drug taking behaviors is all about.
Right. And it's interesting thinking about this from chronic versus acute pain management. And I definitely, with acute pain, limit the numbers of prescriptions or the number of meds that I give. But it is interesting. Reading through this list, and I would encourage people to check it out. I was interested if you have any memorable or interesting patient aberrant behaviors you would like to share.
The premise of the aberrant behaviors again is it harkens back to a conversation that you and I had on a previous podcast where we talked about risk stratification prior to prescribing opioids. And I think I hopefully mentioned at the time that risk stratification is an ongoing thing. And so as new information comes in that like maybe a patient is displaying aberrant behaviors, and then that shifts your risk stratification some, and you take that into account and you adapt the treatment plan. I'll give you an example since I think it's probably apropos to your world of a patient that one of our orthopedists referred to me recently. Now, this wasn't a patient with aberrant drug taking behaviors that we had seen in the clinic, but a patient that just was essentially a high risk patient. Now, she was scheduled for an elective orthopedic surgery. She actually needed, I'll change a few of the details for confidentiality's sake, but she needed a kind of a minor knee surgery, and she actually would end up needing it on the other knee as well. Now, she had a history of heroin addiction, and so obviously, the orthopedist was concerned about the potential for aberrancy and referred the patient to me to manage post-op meds. And the patient had been sober for a while and was actually doing well, but we were concerned about not only would the patient potentially have aberrant behaviors with the post-op opioids, but would this be a trigger for them to relapse on illicit opioids as well? And for this particular patient, we estimated that she would need about 3 days of post-op medication. So, as you know, that would be a kind of a minor surgery, and so we arranged to have a responsible adult um, dispense, a family member, essentially go to the pharmacy, pick up the medications, dispense the medications to her on a daily basis, well, on a three times a day basis. And we did this for the 3 days of post-op, and actually, she just finished her second surgery, and all of this went really well. There was no relapse into heroin use or anything like that. But the point is that you come up with a treatment plan that is commensurate with what you're trying to prevent or trying to safeguard against.
Right, great information. You've mentioned this already, but good practices to follow when we're dealing with these situations in patients. I mean, it's totally different for chronic pain management versus acute care. Certainly, you want to check the pharmacy profile and see, what they look like. And typically, after you've been doing it long enough in an acute situation, anyway, you kind of know when somebody's coming in, what they're looking for. But any other practices that you would recommend? Any other situations?
Well, you're right about the prescription monitoring program really has been a game changer for us in terms of I imagine when people come into your urgent care now, you can easily determine whether they've been, I guess, doctor shopping, as they say, or whether they've been, going from ER to ER or something like that. Legislative movements across the country have tried to reduce the number of pills that are prescribed for acute pain and post-op pain situations. So that's helped a lot. For the chronic pain clinician, I would want to make sure there was a little bit of understanding about what we call pseudo-addiction. Now, that's become a controversial issue, especially with some of this OxyContin litigation, rather, that's come out. But I believe in the concept of pseudo addiction, and pseudo addiction is the idea that patients may be demonstrating aberrant behaviors because their pain is not uh, optimally controlled. with the premise being that if their pain can be better controlled, the aberrancies will stop. Now, what that might look like is a patient who's, you're telling them to take 4 Percocet a day and they're taking 8 Percocet a day because they feel like they need that for their pain. And, the strategies for that specific aberrancy might involve, giving them a higher dose and potentially, things that are less abusable, like maybe a higher dose, but of a long acting medication so that there's not such a tendency to pop so many pills. But the premise being that if you give them a higher dose, then they will adhere to that higher dose and not keep escalating the dose. But if you see that, the more you give, just the more they want, and they just keep taking more and more and more, and it just seems like there's not an amount that they'll be satisfied with, then that's really looking like it's not pseudo addiction, and that's looking like true addiction. The chronic pain clinician does well to understand that concept. I mean, we could talk forever about just how to intervene with aberrant behaviors, but a lot of the simple things we do would be having somebody else store and dispense the medication, and you can certainly do that in your acute pain setting if you have concerns about somebody, but you feel like they would benefit from opioid pain treatment, then get their significant other or parent on the phone and see if you can enroll them in the concept of dispensing and managing the medication for the person. And most patients are completely on board with that, and they're not, offended or feeling belittled by the idea about having somebody else dispense. We would also, other strategies for that type of aberrancy could include, fewer pills but longer acting, because they're less prone to what we call chemical coping, where people maybe just, take impulsively because they find the medication makes them less anxious or less stressed. It's a lot easier to misuse something like if you take 6 Percocet a day, it's a lot easier to take 8 to 10 a day than it is if you take, like, let's say 2 OxyContin a day to take 4 OxyContin. I mean, that's a much more significant aberrancy in my mind, is to overuse a long acting medication. We often adjust the number of pills we would give a patient. So I have patients in my practice that I give them weekly supplies of medications, and maybe they come in every 3 or 4 weeks and see me, and I do a urine drug screen at that time, and I give them their 3 or 4 prescriptions, or whatever, stuff like that. And in the acute setting, the first example I gave was kind of extreme, right? I mean, I gave you an example of somebody that has to have their caregiver go to the pharmacy every day to get 1 day's worth of post-op medications. But there's no reason you can't do that if you have concerns about a patient's risk of aberrancy, or if they've demonstrated aberrancy in an acute pain setting as well. So, I mean, those are just some of many different types. I think I probably talked in the last podcast about the idea of using agents that are less overall abusable, like using partial agonists like buprenorphine as opposed to full agonists like oxycodone and hydromorphone. That's certainly a strategy that I use a lot. I like to use transdermal preparations for some patients. There are some patients, based on either their initial risk stratification or the aberrancies that they've demonstrated in treatment with me, where I think, I'm okay with giving you a transdermal preparation, which is obviously, you have to kind of go out of your way to abuse a patch compared to, multiple dosing, multiple times a day dosing of a short acting oral opioid. So that, there's all kinds of little strategies that I think the sophisticated pain clinician is familiar with. In your acute setting, I think I would try to use some of these things and optimize the success of your acute pain programs as well.
Dr. Marks, great information, and as always, I appreciate your time.
It's my pleasure.
And have a good evening. Thank you for joining the orthoPAC podcast. Join us for our 21st annual meeting in Nashville, Tennessee, PAOS in the Music City, September the 6th to September the 10th, 2021 at the Omni Nashville Hotel. Check PAOS.org for details. Registration is open.